So this is the Penn panel, and I have recruited three fantastic speakers here for us today, and I'll introduce them in the order in which I think we've decided you guys are going to present. Okay, so Neha Patel is going to go first. She's Associate CMIO at Penn Medicine, in charge of mHealth Strategy and Applications, and Assistant Professor of Clinical Medicine in the Department of General Internal Medicine. Next up will be Tessa Cook, who is an assistant professor of radiology and the director of Three-Dimensional and Advanced Imaging Lab. And then finally, Jason Moore, who is the Rose Professor of Medical Informatics and director of the Institute for Biomedical Informatics at Penn, and also the chief of the Division of Informatics in the Department of Biostatistics, Epidemiology, and Informatics. That is a mouthful. Okay, Neha. Mm-hmm.
All right, thank you so much for John and his colleagues for inviting me over today to present and be part of such a great panel. And thank you to the audience for giving us your time and attention. We know it's sort of the last session today. It's been a long day, and we're really looking forward to your questions and a discussion. So I really wanted to spend the 10 minutes that I'm going to have with you guys showing you a little bit about some of the patient digital tools that we've created at Penn. I started in this area of mHealth about 4 or 5 years ago. We're really focused on tools that can help our providers in their daily workflow and how to take care of patients. And in the last year or so, we've sort of drifted and thought about, well, let's think about the patients and what they can use at home, which is what I'm going to show you. So our vision has actually now encompassed patients, providers, and partners for an optimal mobile experience anytime and anywhere. And what's really important, it's defined by this ubiquitous access, seamless integration of information, whether you're at work, the clinical environment, and life. And most importantly, what I get really excited about is this delight by design. So really anticipating the needs of the folks that are using our tools rather than responding to what they want, but also being responsive to what they want as well. So how we started was about 2 years ago. We decided the portfolio at Penn had a lot of provider tools. Let's shift to the patients. And we have a patient portal. We work with Epic. They have a MyChart bedside, a MyPenn Medicine patient portal. Works well. It's got some clunkiness. It doesn't move as fast as sometimes we want it to move. But it really can provide patients clinical information. So we hired design students 2 summers ago. They sat in the cardiology clinic, and we really had them observe and interview patients. Like, what is it that brought you to this clinic? Tell us everything you did at home. Who brought you here? Where's the information? Is it on your phone? And what we saw here was a high-level process map that we created here, in that patients not only had to deal with their coping health issues, but they had to deal with a lot of the logistics, and a lot of the caregivers were working in the space as well. And we thought, you know what, this is definitely an opportunity that we can design something that can support patients better to better health. And at the same time, we saw the effects of patients coming late and the practices having to deal with it, patients not being prepared, and really a limited ability to communicate to patients personalized information. We're still using mail. I don't even check my mail anymore. Well, we check email, but really at home in my condo, my doorman has to call me to be like, your mailbox is full, come pick it up. Because most bills are electronic these days. I know when my package is there, though. I run for that. And so the 3 solutions I want to take you through are pilot solutions. We've been doing it for the last year. I thought they would be great to show you a plethora, a diverse field of what's homegrown, what we're developing at Penn, but also what we're working with other vendors for. And the last is collaboration with Apple Health Records. So the patient visit guide. So as patients come to Penn, when they know their appointment, we have a fragmented way of really informing them. Our EHR system, Epic, has a way to send them an email, although in the email, all you get is log into your patient portal to find out information. A phone call will tell you maybe the doctor's name, but nothing about the location, nothing about the date or the time. And so we created this. This is a screenshot of what it looks like 0 to 15 minutes after a patient schedules an appointment at Penn in our pilot population. They get not only a text, but an email that opens up to this. And I'll show you more about what it actually looks like. And 48 hours before the appointment, they get another personalized link to what we call their visit guide. And here's a demo. The screen actually takes you through the exact demo, what it looks like, and you guys can actually go to this URL while you're sitting here and look at a demo that we created that's public access. But it takes you through the key component that we heard from patients that they were missing. So they were missing a lot about instructions. So each clinic now has an opportunity to create customizable appointment instructions about what to bring, the nuances. Folks wanted to add it to their electronic calendars. Believe it or not, a lot of people were coming with paper and pen and losing it. And what we heard a lot about is just driving to Penn and parking to Penn was really hard and overwhelming for a lot of patients. And so how do you create this so that you really simplify this information? So we worked a lot with our design students. And amenities, what's on campus, what's not on campus? Do we have a pharmacy? Where's the lab? What's the hours? All of this information all at once so patients can get this when they confirm their appointment with Penn, and also at 48-hour mark. Our pilot study has shown that the top 3 features that patients use when they get this web app is actually appointment instructions and add to calendar as soon as they get it. We delved deeper, and a lot of our patients are actually forwarding this link to actually family member and caregivers, because what we realize is usually the patient themselves is not in charge of these logistics. It's usually a caregiver. So we sort of made it easier for them to share this link now. And parking information, if we have a graph of when they're using this link, actually goes skyrocket within 6 to 8 hours of their appointment themselves. The second bullet is actually something we're excited about, in that 93% of patients who open the visit guide show up for the appointment compared to 78%. However, we are now doing a randomized clinical trial to actually make sure we're not looking at a biased population when we look at that data. And those that actually use the the visit guide, actually have a great experience, rating it high. I'm not going to go through the bullet, but definitely areas that we've been able to get patient in their feedback and develop more on. So the other 2 solutions, before I jump into sharing them from you, I want to go over some Apple definitions here. So for those folks, how many folks use an iPhone in the room, just so I know? Just raise your hand. Okay, Android and Google. Okay, so this will more apply for the iPhone users, but I do have screenshots for those that don't use an iPhone. So Apple has created different frameworks for folks to develop information healthcare-related apps. The 2 that are red is what I'm going to talk about. So first is the health app. This is all on your phones. You don't have to go download it, and within it, it consolidates health data from the iPhone, from the Apple Watch, or any other third-party apps or sensors you use. So you could click on your apps, and you're going to get most of you guys the steps automatically, but other people can choose what they want to put in it. CareKit is actually really exciting. 2 or 3 years ago, it's a development framework. So essentially, it's extremely patient-centered. It allows patients to better understand and really manage their condition and track their symptoms, and share that information with providers in a seamless way. So here are actually screenshots of a bariatric CareKit app, an app created that uses a CareKit module. We worked with a vendor called Medical that Apple recommended, and this is for the bariatric population. So current state, a patient that's coming to Penn for bariatric evaluation has to really, when they go over the assessment, has to then have a lot of tasks assigned to them. So they have to be walking a certain amount of steps a day. Some folks actually have to lose weight before they actually get the procedure done. Other folks have to track what they're eating. Areas that can actually help providers come up with a safe surgical plan for them, or even think about maybe surgery is not the best option. The care modules, these care cards, allow physicians and providers to put in a personalized care plan of what the patient's supposed to do, and then the patient can actually track it using the app. The second screenshot is actually what a patient sees the day before surgery about how to prep. The third is actually really exciting. It's a journey card, so patients themselves can actually monitor their own progress in that area. And there's 3 other cards. One is called Insights, that allow us to actually graph in a very patient-centered way what they're doing in terms of their metrics. So we can't just plot and put bar graphs up. We have to use patient-centered terminology to actually help them understand their data. And the last one, I'm not sure if folks came across, there were some newspaper articles about it. We turned it on at Penn sometime in January and February, was the Penn Health Records on your iPhone. So within your health app, you could possibly go in and click on health data, and if your healthcare system that you've got in Careform actually has turned this on, you can actually log in with your patient portal information and see this on your phone. So you can see all of your records, provides a holistic view of what's going on within that healthcare system. And information that you can see is allergies, clinical vitals, conditions, immunizations, lab results, basically different elements that a patient would want to see. What's really exciting about this tool is that it's based on FHIR, and a very simplified way of describing FHIR is basically a standard for transfer electronic medical records information, so that other folks can actually use it and develop apps on top of it using their APIs. What's really great about health records is it has this potential to complement an organization's patient portal. So the patient portal has to still exist because this is a read-only information. The patient portal is actually where you can do your transactions, where essentially you can communicate with your provider. You can maybe set up an appointment, depending on how robust the patient portal is in your institution. And what's really great, and I put here as a slide, an opportunity for third-party vendors to develop apps for patients using this data. So we here at Penn are thinking about ways, how do we leverage this data and come up with an app that makes it easier for patients to, for example, are on top of their screenings, the healthcare screenings, on top of their medications. So there's really a potential to start using this information. This data lives on your phone, so essentially the health record app is not something that you can use on your iPad, because an iPad can be changed amongst person to person, and Apple felt like a phone is really like a personalized device, and if you download it, it's going to stay on it, so it's got the security measures on it as well. So as I end here, what I want to say that this is a really exciting space currently right now in terms of developing digital solutions for patients. The app creation culture is really expanding within our institution. Even though we started with providers and thinking about solutions for providers, we're drifting to patients. There is a gap in things that we have to remember. We have to think about metrics of success of these apps. So what's the effectiveness of these bariatric apps? What's the effectiveness of the VisitGuide app that we've created? Are things that we're still not only struggling with, but also growing in terms of the metrics that we want to track. And last, I just want to leave you with our mHealth Center website, which actually has a catalog of our apps. If you click on it, you will see the patient and family catalog looks really minimal, but that we do have a large suite for provider apps and community apps. But what we show here today, hopefully what I showed you, is in the next few months, we'll actually be able to increase that provider catalog of apps that they can use. And I'll stop here and turn it over to Tessa. Thank you.
Oh, there we go. Good afternoon, everyone. I've really enjoyed the day so far, and it's my pleasure to share some of the imaging informatics innovations that we are working on in Penn Radiology. So what I'm going to share with you falls into three different categories: using imaging informatics to change healthcare paradigms, more for care that occurs in between in-person visits rather than during the in-person visit, a more patient-focused approach to radiology reporting, and the topic du jour, of course, using machine learning for some detection tasks and how we can augment the diagnostic task in radiology. So starting first with some of the novel patient care paradigms, this scenario is one that we face on a daily basis. Patient comes in for example, a renal ultrasound. We find a mass. The radiologist obviously reports the mass, picks up the phone, calls the ordering physician in most instances and says, you know what, there's a mass. I can't tell you exactly what it is. Please get an MRI. And the report ends up in our radiology information system. It ends up in the electronic medical record. And that's sort of the point at which we in radiology lose track of what happens next in the process. One of two things will happen. The physician will communicate the need for follow-up to the patient or not, and the patient will get that follow-up imaging or not. And usually, on both sides of the care interaction, both the radiologist and the ordering physician. The ordering physician might be wondering, am I supposed to order something, and what is it that I'm supposed to order? The radiologist might be thinking, well, I made this recommendation. Did the patient ever get the study? What was the outcome of that? And so we set out, my colleague Hannah Zafar is an abdominal radiologist. She's the PI on this effort. We set out a little over 5 years ago now to try to figure out a way to identify patients at risk for loss to follow-up. And we knew we were going to end up somewhere on this spectrum, anything from a completely manual chart review process to a very expensive automaton that was just going to magically figure this all out for us. So not surprisingly, we ended up somewhere in the middle. And the hybrid approach really involved introducing structure to free text radiology reports so that we could actually mine some meaningful information out of these reports to figure out who these patients are that had follow-up recommendations. So the first piece of this was introducing that structure, and in order to do that, we developed an in-house lexicon named Code Abdomen. The reason for abdomen being that Hannah is an abdominal radiologist, this was the domain in which we started, was abdominal imaging. We've expanded a little bit since then. The individual categories, numeric categories, all map essentially to either a benign finding, a finding indeterminate for malignancy, a finding suspicious for malignancy, or a finding that couldn't be classified for technical reasons. And what we had our radiologists do is for every report that they interpreted, they were now required to put in a structured template that contained this numeric categorization for initially each of 4 organs: the liver, the pancreas, the kidneys, and the adrenal glands. And we chose these 4 organs because in the abdominal imaging space, it was felt that these were the 4 organs where there was the highest frequency of incidentally detected malignancies. So it made sense to start there. Having our radiologists putting in those templates allowed us to then incorporate this monitoring into the workflow. So now the patient still comes in, we still find this incidental mass, the radiologist is still picking up the phone or sending an electronic message to communicate the need for follow-up to the ordering physician, but now we have ARTI sitting in the middle. And ARTI is the Automated Radiology Recommendation Tracking Engine. In full honesty, probably needs a little asterisk there because it's more of a semi-automated engine than a truly automated engine, but SARTI just doesn't have quite the same ring to it. So ARTI it is. But now we have ARTI sitting in the middle, and so the reports that go now into the radiology information system and into the electronic medical record, which are now one and the same, which is not the case when we started this, we can take that data and we can look for these structured templates, and we can figure out who the patients are who've gotten a follow-up recommendation. We can mine the EMR to figure out whether or not when the time interval for that recommendation has elapsed, they've completed their follow-up, or that they are perhaps scheduled in the near future for their follow-up. And for the patients who either missed follow-up or were never scheduled, we now have the ability to send a series of escalating electronic notifications in the EMR to the ordering physician to say, you know, we made this recommendation, we don't have any indication that it was completed. Can you tell us a little bit about what's going on? Do you actually, first of all, the very first question we ask is, are you the right person to be getting this message? Because we don't want to annoy people unnecessarily. We realize that everyone is incredibly busy and probably inundated with a variety of other reminders for things. So if they say yes, then the next question is, do you agree with the recommendation? And if the answer is no, that gives us an opportunity to actually learn something. Perhaps it doesn't make sense in the clinical context of that patient. Perhaps they already know what the lesion is. We just don't happen to know. And so we have the ability to gather a little bit more information. And then ultimately, if we don't get any responses back, this gets escalated to a phone call. So the goal here is to try to keep people from coming back with an advanced undiagnosed malignancy that we could have caught sooner and intervened upon. Just to give you a little preview of some of the things we discovered. So in the first 2 years that we ran the system, in the first year rather, we ran the system, we had just under 30,000 patients that were scanned and included with that reporting template. Of those, about 2,000 patients had findings that were indeterminate or suspicious for abdominal malignancy. We had about 700 that ultimately had follow-up and had their diagnosis downgraded to something benign. We found 200 new cancers. At the time we ran this analysis, there were about 300 patients still in the queue. And then there was that group at the bottom. 907 patients without imaging follow-up, to be specific, imaging follow-up. We understand some of these folks may have gone directly to pathology, but at the time that we did this analysis, we couldn't figure that out. So nearly half of that initial cohort of patients with indeterminate or suspicious findings, and about 3% of the patients scanned for that year. So that was really the group that we were interested in, and we've gone on subsequently to do a number of sub-analyses to figure out why some reasons are the patients don't come back. A good portion of them, instead of going to follow-up imaging, go straight to pathology. So they do get a diagnosis, they just don't get a diagnosis from follow-up imaging. We looked at another cohort of folks to try to figure out what some of the factors were that kept patients from coming back. And we looked at about 1,600 patients with indeterminate findings. About 2/3 of them got follow-up 12 months later. And the remaining 1/3 had some interesting characteristics. They were all tended to be patients who were on the younger end of the spectrum. They all tended to reside fairly close to Penn. This was specifically an analysis that we performed with the hypothesis that the further away you got from the mothership, as it were, the less likely it was for people to come back for follow-up. Turns out we were wrong. A lot of these patients were from a patient population that really seemed like a disadvantaged population. They would have one interaction with our health system, usually through an emergency room visit. They were usually uninsured or underinsured on the younger end of the spectrum. So this data actually has prompted a multidisciplinary collaboration between radiology, the emergency department, and our hospitalists to try to figure out a better way of capturing these patients and perhaps even connecting them to a primary care physician after they leave our health system. A little bit to share with you about the notifications to ordering physicians. So taking 110 patients with recommendations and going through those electronic messages that I mentioned, I looked at the last couple of months worth of data, and we get about a 33% response rate, a little bit more than that. But you can see of the 34 respondents in the panel to the right, the vast majority of them we have now been able to close the loop on. There were 4 physicians that responded and said they were the wrong person to send a message to. There were 5 that disagreed with the recommendation, but there were 7 that were actually going to order a follow-up study as a result. And I interestingly got a very enthusiastic phone call from one of our primary care docs in the reading room a couple of weeks ago who started congratulating me profusely, which was actually really kind of fun because that doesn't really happen in our line of work, as I'm sure many of you know. But the system is having an impact, which is a really great thing to hear. And I would be remiss if I didn't acknowledge the team. Hannah Zafar, as I mentioned, is my co-PI. We're doing this with the support of Mitch Schnall, who's our chair, and Chuck Kahn, who's our vice chair. And I do have to acknowledge Darko Lalovic and Charlie Chambers. They are the Center for Translational Imaging Informatics developers. I direct the center, and they are the ones that have built a lot of the tools that you'll see in this presentation, already just one among them. So we used a lot of the machinery that we developed for ARDI to start to spin up this hepatocellular carcinoma screening effort. This was a project from Dr. Joe Wildenberg, who was one of my informatics fellows last year. He is about to go start his grown-up job as an interventional radiologist. And Joe got interested in the problem of screening for HCC, and we talked about screening for Hep C earlier in this forum. But the American Association for the Study of Liver Diseases recommends basically Q6 month, specifically ultrasound, but we've kind of broadened it to liver imaging of some kind for patients who are at risk for hepatocellular carcinoma. And from the literature, we know that there's a broad range, but very few of these folks actually get their regular screening. And so one of the things that Joe was interested in trying to figure out is, could we create an intervention directed at the physicians managing these patients to create a set of reminders for regular screening, because this is not something that's already built into the EMR. So we are working with Dr. Dave Goldberg, who's one of the hepatologists, and hoping to actually pilot this in the near future, and hope that that blue bar that you see at the bottom, which is the number of patients that are actually compliant with Q6 month screening, starts to budge a little bit. This is work from another one of my informatics fellows from last year, who is also soon to be an interventional radiologist, Dr. James Chen. took a crack at the problem of the monthly biopsy review in interventional radiology. So this was previously an entirely manual task where they had one system that they recorded all their complications in. We have another system where all of our radiology reports go, and then we have the EMR where the pathology lives. And James wanted to figure out a way of automating this, and he was very successful in doing so, and shaved 75% of the time off of what the fellows normally spend doing this in a very manual, tedious process. He also improved the capture rate, so they found biopsy results that were not actually represented in some of those other systems by tying all of the databases together. So this was a really nice effort that we're hoping to roll out now beyond just interventional radiology in the department. So in the last few minutes, I want to tell you a little bit about Porter, which is the Patient-Oriented Radiology Reporter. This was the brainchild of Chuck Kahn, based on a conversation with a patient who has all of her care at Penn Medicine and has regular imaging as a result of her medical conditions. And she said every time she got a report, she would take it and she would share it with another friend who had another medical condition, and they would kind of dissect all of the wording that the radiologists had used. And things that very innocuous terms that are just sort of colloquial among radiologists that had a completely different meaning to patients. So it was a very eye-opening conversation. And so Dr. Sung-Oh was one of my informatics fellows a couple of years ago, was a musculoskeletal radiology fellow in his clinical life. And so we started to look at whether we could create an annotated radiology report for patients. Started small initially with knee MRI. We subsequently expanded it to other body parts and other study types. But we actually embedded a little note in the radiology report. Dear patient, your report is available online at this secure website. Take this code, type in your date of birth, and get the explanation. And so we were really targeting folks that were going to read their radiology reports, more than likely through the portal, but perhaps in some other way. And so when they went to the website, they would get this annotated report, and it was exactly the text of their radiology report. You can see some of the terms are hyperlinked, and if you moused over the terms, you would get a definition. In some cases, a hyperlink to Wikipedia, so they could read even more. We tried to collect some public domain illustrations, so in cases where there was an image available to accompany the term, we would provide that as well. And we wanted to reinforce the fact that this was a physician-generated interpretation, so every report was accompanied by a headshot of the radiologist that had done the interpretation. You see Dr. Bruce Nealon there, the bottom right corner, who's our outgoing division chief of musculoskeletal radiology. We did a short pilot with patients and generally got very positive feedback. One very meaningful piece of feedback was, this doesn't replace a conversation with my orthopedic surgeon, and I wish I could shake that patient's hand because I agree, this just shouldn't replace a conversation with your orthopedic surgeon. The goal was really to try to provide a little bit more communication from us as the radiologists that we can't normally embed in a radiology report. One of the members of the team, Tessa Martin Carreras, is one of our rising third-year radiology residents. So she's taken this one step further and starting to look at the challenges of readability for the resources that we provide to patients. So with Porter, we've really tried very hard to make the terms and the concepts to design them at an appropriate reading level. And she did a comparison of Medline Plus and Radlex, which is a radiology ontology. And they are much more skewed towards higher grade levels than Porter is at present. So just to conclude, work from two other folks that I've had the pleasure of working with, Dr. Andreas Rauschecker, who's about to be a neuroradiology fellow in California, has been working on a start-to-finish automated pipeline for extraction of features and injection of them into Bayesian networks to provide automated differential diagnoses. So all of the processing you see in the graphic on the top is done in an automated fashion. All of that quantitative output gets injected into the Bayesian network, and it comes back essentially as radiologist decision support. Here are the features, here are the diagnoses I think you should consider. He has benchmarked this against radiology residents. It outperforms them. It outperforms radiologists who don't typically read neuroradiology studies. It does not outperform board-certified academic neuroradiologists at Penn. So their jobs are still safe. And Bob Liu, who is a second-year medical student has been working with me looking at NLP and machine learning to try to extract follow-up recommendations. So this very much getting back to the work on RD that I showed you earlier, where if we're relying on the radiologist to create the content, at some point you're going to end up with false positives and false negatives. Could we use an algorithm to help us supplement identifying those folks? And finally, I know that the popular notion these days is the man versus machine, and I have to look over my shoulder every day, even though I don't really, because I'm not worried about the machines taking my jobs. I think it's going to be a very collaborative effort, something a little bit more like this. I personally think it's a fantastic time to be a radiologist because this is like our next new modality. The generation of radiologists that trained me had CT and MR. I have artificial intelligence. It's a great time to be a radiologist. So thank you very much, and I'll be happy to take questions in the panel.
Okay, good afternoon. Pleasure to be here with you. In my role as director of the Institute for Biomedical Informatics at Penn, one of the things I'm interested in doing is bringing machine learning and artificial intelligence technology to everybody. And so I'd like to, this is a longer presentation, but I'm going to hit a couple highlights and tell you about a new system we've developed at Penn that we want to roll out to the entire community here at Penn, CHOP of course, and the rest of the world by the end of the year. So John Holmes and I wrote an editorial recently making the case that this is the golden era of biomedical informatics, and I think the bullet points on this slide would resonate with all of you. And we thought about what's next. What can we expect in this golden era that will probably last a long time? And I agree with Tessa, it's a really good time to be a radiologist. It's a great time to be an informatician. Artificial intelligence, of course, I think is going to play a very important role in addition to these other things I've listed. And AI has a very interesting history in medicine, and it's the basic idea that, of course, that we can get computers to plan, solve problems, and reason. And Alan Turing asked the famous question in the 1950s, can machines think? And how would you know if a machine could think? And that became affectionately what we've called the Turing test for many years. That you would be sitting at your computer having a conversation with your friend, and then your friend would later tell you that you were talking to their computer and you would not know the difference. Then the computer would be said to pass the Turing test. And this is an exciting time right now because there are computers and software that are making the case that they are passing the Turing test. This is one of the famous ones that was in the news a few years ago, Eugene Goosman's chatbot. That fooled a number of human experts, and of course you probably saw Google's new automated assistant that was able to make a haircut appointment over the phone without the real person on the other end knowing it was a computer. So we're in that time right now. This is an exciting time in AI because we're in that time when computers are starting to pass the Turing test. So I'm going to skip through some of this. And by the way, I'm happy to send a PDF of all the slides to anybody. Just email me at jhmoore@upenn. Watson was a real turning point in AI. In 2010, beat the Jeopardy champion, and this was a real tour de force in AI. And the story of how Watson came to be is really very interesting, and it was a really very impressive effort. And of course, IBM has now built their whole business model around Watson, delivering Watson to healthcare, which is not really ready for prime time, as we learned from its experience in the oncology arena with MD Anderson pulling out of Watson after spending $60 million on it. This is a paper in AI Magazine from 2010 going over the history up to that point of the Watson project. It's kind of a dry read, but there's some really interesting points in there about how they came together to overcome a number of barriers. So I'm interested in AI for data analysis. How can we get AI to automate machine learning and make data analysis easy? Because we live in a big data world. We all want to do machine learning. Machine learning is inherently very difficult and not accessible to most people. So this is how I think about the data analytics pipeline. I'll just step through these one at a time. So we start with big data, of course, and data is very messy, heterogeneous, and big. We need to integrate that data so that we can ask impactful questions from multiple different data sources. You might want to do some feature selection because the number of variables may be too large to put into a machine learning algorithm realistically. So we might want to use algorithms or our knowledge of biology and medicine to generate a subset of features that we can use in the analysis. We might want to recode the data, put it on a different scale, combine features to make it easier for the machine learning algorithm to find the pattern. The data doesn't always come to us in the right format. And then, of course, the part of this that most people really struggle with is the machine learning part. Getting to the point of actually picking a machine learning algorithm is problematic because every machine learning algorithm works differently on different data sets. And you don't know before you start with your particular data set which machine learning algorithm is best. You might have some ideas about which machine learning algorithms work better than others, but you really don't know for your particular data set. And then even once you pick a machine learning algorithm, you have to pick the parameter settings, which also requires a lot of knowledge. So there's a lot of technical expertise that goes into machine learning, and even those of us that do this on a daily basis struggle with it. It's an ongoing battle to really figure this out. Now, once you have a good model, then of course you need to interpret it and then validate it, and then hopefully lead to a clinical application. So why artificial intelligence? I'm deeply interested in how we as humans decide to do an analysis. So if I was to give a data set to everybody in this room and say, let's come back next week and compare notes, every one of us would take a different path through that data set, right? We would pick different methods, some statistical methods, machine learning methods, other methods, depending on our training, our expertise, our experience, our knowledge. And so I'm interested in that process. How do we do that? How do we make decisions about what analytical methods to use? And more importantly, can we get a computer to do that? Can we get a computer to automate the data analysis process? So we started a project about a year and a half ago called Penn AI to build a system for automated data analysis and machine learning. And the mantra of this project is that AI should be open, easy, and accessible. It should be just like using your smartphone. The tools are there, the technology's there, the software is there. We just have to make it work for us. So we built a system called Penn AI, and I'll just step through the components of Penn AI. The first thing we needed was a machine learning engine. Fortunately, we didn't have to build that. The scikit-learn library is a Python library that is free, it's open source, very comprehensive, very professionally done. So we were able to pull this in. We didn't have to code our own machine learning algorithm, so that was nice. The next thing we needed was a controller. We needed a way for the computer to grab some data, grab a machine learning algorithm, run it on a cluster, get the results back, and then do something with those results. Now, we had started developing our own controller when I ran across something called Future Gadget Lab on GitHub, which is an open source project from Europe that does exactly what I just described. So we were able to bring this in and incorporate it and link it with scikit-learn. So we didn't have to build this. That was nice. That saved us a few months of development time. Then the next thing we need is a database. We need, for a system to be able to learn from prior analyses, it needs a memory. It needs a place to put the results of a machine learning analysis. Now, what most of us do is we analyze some data using maybe several different methods. We pick the one that works the best. We publish that. All the other analyses we do sit on our hard drive and eventually go away, right? Nobody ever sees those. And so by having every result you ever generate on every data set in a database, then the artificial intelligence can then make use of that to learn what machine learning algorithms are working. So we used set up a MongoDB database, which is a type of document store, also open access and freely available. And so our machine learning results come back to us from the controller in JSON format, and then they go right into MongoDB. And now we can search and learn from every machine learning result we ever generate. Okay, so now we have all the raw materials. Now what we need is the AI piece, and we developed that ourselves. And essentially what we developed was a recommender system, just like what you see on Netflix or Amazon. The AI looks at all of the data, all of the results that are in the database, and does an analysis to determine which methods are working better than which other methods on which kinds of data sets. And so we literally create a data matrix of results, looking at the performance of each analysis along with what machine learning method was used and the meta features of the data set, the number of features, the sample size, the correlation structure, the types of features, et cetera. so that the AI can have some context about what machine learning algorithms are working on, which kinds of data sets. So we do an analysis that creates knowledge, and then the AI can use that knowledge to automatically launch machine learning jobs for you. So the AI determines what it thinks are the best algorithms to run on your data and then can do that automatically. So the last thing we need is an interface. So we built a user-friendly interface in JavaScript. So when you log in through a web browser. You do this through your smartphone. You see your data sets in boxes, and then you can see the number of results in the database for each data set in the bottom right panel of each square. So that first one, the adults data set, has 26 machine learning results in it. You can click on that button and get a table with all the results. You can sort through them. You can explore them. And then you can see the AI button there on the top right of each panel. When you turn that on, the AI will start analyzing your data automatically. So it's that easy. Once you get your data in the system, you push that button, you're done. The AI will do the analysis for you. And then feed the database, and then you can explore those results. Now, you can also do an interactive machine learning analysis. So we've created a very simplified push-button interface here with some preset machine learning methods that are commonly used, some preset parameter settings. So you just click, 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 hit go, you're done. Machine learning is that easy with this system. I like to say it's so easy a 2-year-old can do it. You put this on an iPad in front of a 2-year-old, they can do AI and machine learning. And then as you explore the results, we're creating a results dashboard. Right now we're in the process of evaluating Penn AI across a whole bunch of different data sets to see how well it works. We have a paper up on archive describing Penn AI. We have a webpage, pennai.org. And like I said, we're coming to the end of the development of the first version of Penn AI. We'll be done by the end of the summer. We're going to release this to the Penn community. So if you're interested in being a beta tester for Penn AI, definitely reach out to me. We're going to sign up probably 10 or 12 different groups to start playing with using Penn AI to give us feedback, and then we want to put it out on GitHub as open source by the end of the year. That's our goal. So, and I'll stop there, but just to mention, we've been getting some press already for this tool. You know, a lot of AI is wrapped up in commercial software, right? You have to go out and pay a vendor for AI software. And that's problematic, especially for the healthcare area, because it's a black box, right? These companies, Watson doesn't tell you what it's doing. It doesn't tell you what's under the hood, where those answers come from. And if you're going to make a treatment decision for a patient based on a black box, a lot of clinicians don't feel comfortable with that. So what we've developed is a completely open, completely accessible system where you can look under the hood and you'll know exactly where your answer came from. And this was a article about Penn AI that was in Motherboard magazine. And the writer was particularly interested in this idea of democratizing AI, right? That this will be disruptive, this will be accessible to everybody, and you can look under the hood and see what it's doing. So I'll stop there and look forward to the panel.